Hello, today I'm going to present the case titled Preemptive Alcohol Septal Ablation Prior to Valve-Involved Transcatheter Mitral Valve Replacement with a Bioprosthetic Balloon Fracture. I'm Pedro Engel Gonzalez from UT Southwestern. The case involves a 78-year-old female who underwent a surgical mitral valve replacement with a 25mm mosaic bioprosthesis in 2004. She immediately developed mild dynamic LVOT obstruction due to the interaction between the anterior portion of the prosthetic valve and the basal septum. At the time of referral to our institution in 2019, she was already experiencing heart failure symptoms refractory to medical therapy. A transthoracic echo showed severe bioprosthetic valvular degeneration resulting in severe mitral stenosis with a mean gradient of 12, a velocity of 4.6 across the LVOT, and a subaortic septal thickness of 16. She was not a surgical candidate due to her multiple comorbidities and frailty, hence a TMVR was planned. Valve-involved TMVR is an acceptable treatment option for high surgical risk patients with severe valvular degeneration of mitral bioprosthesis, and its use is increasing in the U.S. TMVR carries an inherent risk of acute LVOT obstruction, which is also potentially fatal in patients with predisposing anatomical factors, like this patient with mild LVOT obstruction at baseline and anticipated bioprosthetic valve fracture because of her small surgical valve and the elevated transvalvular gradient. A preemptive alcohol septal ablation is emerging as a promising and safe strategy to allow for basal interseptal myocardial wall remodeling before TMVR to prevent LVOT obstruction. Application of a preemptive alcohol septal ablation prior to valve-involved TMVR with a bioprosthetic fracture has not yet been reported in the literature. CT angiography was used to create a multiplanar gated reconstruction of the predicted neo-LVOT in unsystole. A neo-LVOT area of less than 189.4 millimeters squared is usually considered high risk for LVOT obstruction post-TMVR. Our patient's neo-LVOT with a 23mm Edwards sapien 3 valve was 252.4 millimeters squared, which is above the conventional threshold, but still concerning given the anticipated bioprosthesis fracture. After discussion with an interdisciplinary team and the patient, the decision was made to proceed with a preemptive alcohol septal ablation strategy. Here in Figure 1, we can see the CT angiography mitral valve reconstruction with a computer-aided modeling of the neo-LVOT with a 23mm Edwards sapien 3 prior to alcohol septal ablation showed a predicted area of 252.4, just as previously mentioned. So an over-the-wire 2.5mm balloon was deployed in the second septal perforator in order to perform the preemptive alcohol septal ablation. Angiography showed a competent seal, and echocontrast was used to confirm flow to the area of interest by transthoracic echo. Administration of 1.5 cc's of 98% dehydrated alcohol was performed over 10 minutes. A transthoracic echo 4 weeks post-ablation showed an akinetic basal interseptal wall and a small decrease in intraventricular septum width and no dynamic LVOT gradient. Here in Figure 2, we can see the coronary angiography during the alcohol septal ablation. We can see the 2.5mm balloon in the second septal perforator prior to the injection of alcohol. In Figure 3, we can see two TTE parasternal log axis views. One panel A is basically the pre-alcohol septal ablation image that showed a dynamic obstruction of the LVOT by the anterior portion of the bioprosthetic valve, which protrudes against the septum in mid-systole. In panel B, we can show the post-ablation TTE, which shows a reduction in the thickness of the basal septum and no significant LVOT gradient. So we perform transseptal valve-involved TMVR 5 weeks after the successful alcohol septal ablation. Immediately following implant, a mean gradient of 8 was noted across the TMVR and none across the LVOT. A bioprosthetic valve fracture was performed under rapid ventricular pacing with a 24mm true balloon. Fracture was confirmed by the release of the balloon waste and sudden drop in the inflation pressure. The mitral gradient was reduced to 5, and there is still no gradient across the LVOT. Here in Figure 4, we can see the deployment of the valve-involved TMVR. The 23mm Edwards sapien 3 valve can be appreciated in the mitral position And here we can see the bioprosthetic valve fracture. Basically, it was performed under rapid ventricular pacing with a 24 mm balloon, just as mentioned, and fracture confirmed by the release of the balloon and a sudden drop in the inflation pressure. A transthoracic echo was obtained 30 days after this procedure, which showed similar hemodynamics, and her symptoms were significantly improved. Preemptive alcohol septal ablation prior to TMVR has been reported most in patients with severe microannular calcification, in some patients undergoing valve-in-valve TMVR. This case was novel since it involved a patient with mild dynamic LVOT obstruction at baseline undergoing valve-in-valve TMVR with bioprosthetic valve fracture due to the small size and high residual gradients. Clinicians are likely to face this clinical dilemma more often as the rate of utilization of valve-in-valve TMVR increases. Our case demonstrates the feasibility of a preemptive alcohol septal ablation in this type of clinical scenario and adds to the armamentarium of the treating interventionalist. Other strategies like intraprocedural intentional laceration of the anterior mitral leaflet to prevent LVOT obstruction and a bailout alcohol septal ablation have been employed as potential alternatives and solutions to prevent the iatrogenic LVOT obstruction. Now, a lampoon procedure is technically challenging and few operators have the experience to perform this procedure. An bailout alcohol septal ablation strategy has been reported, but mortality remains high given the extent of hemodynamic compromise in the acute situation.